So what is the treatment for early breast cancer? We'll talk about early breast cancer first. Two options. One is, suppose this is the breast cancer, this is the axillary tail, this is the nipple areolar complex. So early breast cancer, the options are mastectomy, to remove the breast completely, mastectomy. We call it as modified radical mastectomy. Earlier it used to be radical mastectomy. Nowadays it is modified radical mastectomy. We'll see what is modified. Okay, this is mastectomy first of all. Then nowadays the concept is conservation. Every time partial nephrectomy. What is the other name of partial nephrectomy? Yesterday I told you.
Nephron sparing.
Yeah,
NSS.
we'll spare something so that it will be useful. Okay, in the same way, breast conservation. Suppose the lesion is here, we will take this part out only. Breast conservation. With breast conservation, with 1 centimeters to 1 millimeter margin, at least a single cell margin is enough. We call it a single cell margin, 1 centimeters to 1 millimeter. Okay, so this is a breast conservation surgery. 1 millimeter margin will take. We have to keep it up. So breast conservation with radiotherapy. After breast conservation, we'll give radiotherapy. We call it as radiotherapy. Because why we'll give radiotherapy? Can anybody tell me? We have taken the lesion out. So why to give radiotherapy?
Is it to prevent recurrence?
Yeah, to prevent recurrence, because breast cancers are multifocal, multicentric. There may be a small foci somewhere here, and all. Okay. So to prevent that, we'll give radiation therapy. Okay. So BCS plus radiation therapy. That is the combined treatment. There is no only breast conservation. You can't just remove the lesion and leave. After removing the lesion, you have to give a radiation therapy. So one is mastectomy and one is breast cancer conservation surgery with radiotherapy. Okay. So then mastectomy. We'll talk about mastectomy and then we'll go into breast conservation. Mastectomy, earlier days it used to be radical mastectomy. Once if you open any surgery textbook, they will give Halsted, which is known as Halsted. The surgeon known as Halsted, he used to do this radical mastectomy. Like the entire breast along with the muscles, rib, everything he used to take it out. There used to be a deep cave-like thing here. Okay, once the breast is removed, everything is used to remove, and there used to be only a cave-like lesion. Okay, there used to be that cave. You understand, right? There should be depth excavation. Then, after a few generations, there used to be called as modified radical mastectomy. Modified radical mastectomy is we are doing only a part of, we'll remove the breast, but we are not removing the chest wall entirely. Only a part of chest wall we are removing. And then, 1 minute. Yeah. So what is simple mastectomy? Anybody? What is the difference between simple mastectomy and radical mastectomy, modified radical mastectomy? Both are removing breast, no doubt. Mastectomy is removing the breast tissue, no doubt. But what is the major difference?
Slightly more stuff is preserved in simple mastectomy.
No. Okay. See, in modified radical mastectomy, we will remove the lymph nodes also. We are removing the lymph nodes also. Whereas in simple mastectomy, there is no need to remove the lymph nodes. Okay. Simple mastectomy is not oncologically correct. It is oncologically incorrect operation. That means we have to remove the lymph nodes whenever we do a breast cancer surgery. So it is just, in which cases we do simple mastectomy? Can anybody tell me which cases we will do a simple mastectomy?
Benign
tumors. Yeah, large benign tumors. Small benign tumor not necessary. Large benign tumors like Phyllodes tumor will remove the breast cancer. Will remove the entire breast. And also, if there is a large fungating lesion on the breast, fungating lesion, then we will also do a simple mastectomy. The other name for this mastectomy is, can anybody tell me? A large fungating growth is there, awkward fungating growth, an ulcer is there. Then we'll do a simple mastectomy. Any other name for it heard in your surgery classes?
aspergillus.
Toilet mastectomy. We know it as toilet mastectomy. Okay.
No,
okay.
sir, never heard this term.
Okay, never heard. Okay, fine. So this is about radical mastectomy. Following, right? Radical mastectomy is nothing but removing the, what is radical mastectomy? Removing the breast, nipple areolar complex, pectoralis fascia, major muscle, minor muscle, level 1, 2, 3 lymph nodes. Everything is removed. This is radical. But modified radical is preserve pectoralis major. Once you remove the pectoralis major, this chest wall will be deformed. Okay, so preserve pectoralis major. No need to remove pectoralis major. But pectoralis minor, we have to see. Till now it is clear. Radical mastectomy, remove everything. Modified
Yes,
radical
sir.
mastectomy, pectoralis major is preserved. That is the point number 1. Then what about pectoralis minor? Pectoralis minor, this is suppose this is the pectoralis minor. In modified radical mastectomy, 3 surgeons are there. No need to remember these names, but just for completion's sake, Pate, he came. What he did, he removed pectoralis minor completely. He preserved pectoralis major, but removed pectoralis minor. Then came Stanlon. He divided it, removed the tissue, again closed it. And now what we do is Akin-Claus. Akin-Claus, what he did is just retract it. No need to remove the pectoralis minor, just retract it. That's all. Okay, that is what Akin-Claus is doing. So now we do Akin-Claus technique only. We just retract the pectoralis minor muscle. And pectoralis major, is it removed or not removed? Major.
Not removed.
Not removed. Pectoralis major is not removed. Minor also is not removed. It's just retracted. That is modified radical mastectomy. But radical mastectomy,
Complete resection.
complete. We'll resect the major, minor, everything. Simple mastectomy,
Removing
Benign
money.
tumors.
yeah, for benign lesions. Toilet mastectomy for fungating lesions, phyllodes tumor, and ductal carcinoma in situ. What is the growth pattern of ductal carcinoma in situ? Which type, which pattern? Which pattern that is?
Comido pattern.
Comido pattern, excellent. This is the Comido pattern. Okay. So see, this is the left radical mastectomy. This is the incision. This is the Halstead's incision. We take out the lymph nodes. We take out the breast tissue. Okay. This is one thing. And what are the complications of modified radical mastectomy? Most common is seroma. See, here many lymphatics are there. Once you damage the breast tissue, there is accumulation of fluid. That is, seroma formation is there. Most common complication is seroma. Most common injured nerve is intercostobrachial nerve. Okay, because intercostobrachial nerve runs like this. The most common nerve to be injured is intercostobrachial nerve. And most common cause for unilateral edema is post-mastectomy lymphedema. There will be lymphedema. It is most common cause, unilateral lymphedema. Why this lymphedema? Anybody? Why after mastectomy lymphedema will be there?
Because of the resection.
Yeah, due to the resection, and we remove the lymph nodes also, right? So the draining lymphatics are disturbed. Okay. So
Yeah,
once we disturb the lymphatics, will be accumulation of fluid. So there will be
Yes,
post-mastectomy
yeah.
lymphedema. And there will be long-standing edema will lead to Stewart-Treves syndrome. Stewart-Treves syndrome. Long-standing edema will lead to Stewart-Treves syndrome. Okay. And these are the complications. Most common seroma, most common injured nerve with intercostobrachial, most common cause of upper limb edema is post-mastectomy lymphedema. Okay. And then we have to preserve these 3 structures. What are these ABC? Anybody? Preserve ABC.
Sir, is A axilla?
A is
Axilla. Sorry, I'm just guessing.
axillary vein. C is cephalic vein.
Okay.
B is long thoracic nerve of Bell. Long thoracic nerve of Bell. Long thoracic nerve of Bell. We call it, right? You know, right? Long thoracic nerve. To ring
Yes,
the
sir.
bell, we use long thoracic nerve of Bell. Yeah. So axillary vein should be preserved. Long thoracic nerve of Bell should be preserved, and cephalic vein should be preserved. These 3 are to be preserved. So if you don't preserve a long thoracic nerve of Bell, this type of complication will be there. What happened here? Anybody?
Winging scapula.
Yeah, very good. It is winging of scapula. Winging scapula. Because the long thoracic nerve of Bell is injured, there will be winging of the scapula. Okay. Then this is mastectomy. Okay, you know what is mastectomy, what is radical, what is modified radical, what is major, what is minor. That you know. Then you know about toilet mastectomy. That is simple mastectomy. Then you know what are the complications. What is the most common complication?
Seroma.
You know the complications. You know what to preserve in a mastectomy. And then we'll talk about lymph nodes. Axillary lymph nodes. Just these are numbers. You have to, and What is the single most important predictor? Single most important predictor for prognosis.
Axillary lymph node involvement.
In penile cancer?
Inguinal.
Inguinal lymph node.
Lymph node status. Very good. Very good. So, lymph nodes, I'll discuss what are the various groups of lymph nodes. We'll discuss in the upcoming session. But for time being, at least 4 for sampling. We call axillary node sampling. 4 lymph nodes should be there. SLNB is sentinel lymph node biopsy. Sentinel lymph node biopsy. At least 2 you should take. For axillary lymph node clearance, at least 10 you should take. Remember these numbers. For lymph node clearance, 10. For lymph node biopsy, 2. For sampling, 4. 2, 4 and 10. So, what is the concept of sentinel lymph node biopsy? SLNB, what is that? Anybody? What is sentinel lymph node biopsy?
First lymph node were involved.
Yeah, very good. Sentinel means guard. Sentinel is guard. If you can see the Buckingham Palace and all, people will be standing with arms. Okay, so those 2 people are known as sentinels, the first guard. Okay, so this is the breast. These are lymph nodes scattered over here. So the breast tissue, it will go to the first this lymph node and then 2, 3, 4 and 5. So this first number 1 lymph node is known as sentinel lymph node. The concept behind it is, people came up with the concept that while doing surgery, just remove the breast completely and remove this lymph node. Take that lymph node and see whether there is malignancy inside it or not. If there is malignancy, what to do? If there is no malignancy, what to do? Tell me, if there is malignancy in the first lymph node, what to do?
Should be removed.
Second lymph node. Remove all the lymph nodes.
Yeah, if there is malignancy, remove all the lymph nodes. If there is no malignancy, what to do?
Preserve it.
Preserve it. No need to do. No need to do lymph node dissection. Okay. Why this much? It is just a lymph node, right? We can just take it off. Why are we bothered most about these lymph nodes? We are removing the breast, but we are bothered about lymph nodes. Just lymph nodes, right? Sorry?
Because it can lead to metastasis.
Okay, no. That's what we can remove the lymph nodes, right? We are worried about metastasis. So why to study that lymph node? Why to give some dye and why to identify the first lymph node and then carefully, yeah. Why we need to remove the lymph nodes? We are worried that there is metastasis in the lymph nodes. So why we are taking so much pain to preserve the lymph nodes? That's what is my question.
If there is
So
lymph node,
basically, the lymph nodes receives direct lymph directly from the tumor. That's why.
Yeah. No. You are maybe some.
No. This is about preserving it because, I mean, it has its own function. So
immune suppression.
Lymph node function.
Yeah.
To produce the defense
Most
function.
of the complications of breast cancer surgery, like seroma, like everything, lymphedema, everything will come from dissection of lymph nodes only. They don't come from removing the breast. Removing the breast, no side effect at all, no complications at all. But even malignancies, everything will come because of removing the lymph nodes. That's why we are very skeptical about removing the lymph nodes. We will not remove lymph nodes like that. Okay, so they are small, tiny lymph nodes. They have a lot of bearing in the complications. So we always remove the breast and just we try to preserve as many lymph nodes as possible if feasible. That's also there. Because if they are already metastatic, we can't do anything, helpless. But if there is no metastasis, which happens in some cases, then we will identify the first lymph node. Identify the first lymph node, take it, see under microscope whether there is pathology in it, whether there is malignancy in it or not. And if there is malignancy, we have to remove the entire lymph nodes. That's it. Clear now?
Okay, sir.
Yes, sir.
Infections, sir. Lymph nodes help in infection also, right?
Lymph nodes help in?
Infections.
Yeah, to control infection. Yeah. They are the nullifying organs, right? First defenders. Okay. Yeah. So this is one thing. And then breast reconstruction. You have removed the breast. Okay. So how to reconstruct it? See, this is the breast.
Sorry, I'm still a little confused. So I just want to know, so what levels of, for example, we have stage 1, stage 2, stage 3 and stage 4, right? So on what level, say for example, it is stage T1, T2, what surgery would be performed, and would we include the adjunctive chemotherapy? Because this is, for as I remember, that we do that. You know, we do adjunctive chemotherapy.
That's there in the next slide. Chemotherapy, which patients to give, radiotherapy, which patients to give.
Okay.
But see, for your question, we are now talking about only early breast cancer. I have not come to locally advanced or metastatic breast cancer. Okay. So I'm talking about only about early breast cancer. That is lesion confined to the breast and single mobile axial lymph node. No matted also. Single mobile axial lymph node. Okay.
Got it. Okay. Okay. Got it.
So I have removed the breast. We have done radical mastectomy. Then what to do? So here, see this. This is the rectus abdominis muscle, RAM, rectus abdominis muscle. So this is transverse rectus abdominis muscle. We take this muscle and we used for reconstruction. Okay. So we'll just take a flap from here and we will reconstruct. Okay. So the most common used is reconstruction is transverse rectus abdominis muscle, and any flap, it is vascular based. It has a vascular supply. It is from DIP, deep inferior epigastric perforator vessel. Deep inferior epigastric perforator vessel. This is the perforator vessel which will be useful for the supply of this graft. Okay. Clear? So any other option of breast reconstruction which we discussed in the morning? Breast reconstruction is by using which gel?
Silicone gel.
Silicone implant gels. Okay. That is one option. Or you can do an autologous. This is homologous. You just use the patient's abdominal muscle and just reconstruct it. Okay. So this is breast reconstruction. And then we are talking about BCS. BCS, never BCS alone. It is always BCS plus
Radiotherapy.
Radiotherapy. Yes, very good. Why is it so? I'll tell you. See, so the contraindications for breast conservation surgery is pregnancy. Why? Only breast conservation we can do. But breast conservation alone is not the treatment. We have to give radiation therapy also. So in pregnancy, can we give radiation?
No.
Even if you are not able to do an X-ray in pregnancy, then how can you give radiation? So no. In the same way, collagen vascular disease, contraindication to radiation therapy. Prior RT, radiation therapy given prior. No, you can't give again. Multicentric, multifocal, lobular cancer, locally advanced breast cancer, large tumor, locally advanced. These are all the contraindications. You can't do BCS in locally advanced. See, it has spread already. It is a big mass. It has spread to the chest wall. It has spread to this underlying. So you can't do a breast conservation there. So simple, logical, nothing much to remember also. So whichever is the contraindication for radiation therapy is a contraindication for BCS, and whichever is a contraindication for large tumor is a contraindication for BCS. Okay. Yes. Yes. No.
Large tumor is contraindication for BCS, and
Large tumor is contraindicated, obviously, right? Breast conservation only for small tumors.
Yes, sir.
Yeah. And here in one point, why is this? See here, lobular cancer. I have added lobular cancer. Why is it so? Why lobular cancer specifically is a contraindication for breast conservation?
Due to reoccurrence.
Due to
Reoccurrence.
recurrence. Yes, due to recurrence. And I told you it is multicentric. If you suppose it is removed here, you give radiation entirely, but even after giving radiation also there is chance of the lesion recurring. So lobular cancer, if there is finding of lobular cancer, it is BCS you should not do. You should do MRM only. Okay. And then as somebody has pointed out, like chemotherapy, when to do chemotherapy, when to give chemotherapy. Okay. So what is this neoadjuvant and what is this adjuvant?
Before surgery, after surgery.
Yeah, neoadjuvant is the one which is given before surgery. Neoadjuvant is before surgery. And adjuvant is after surgery. Okay. So early breast cancer, MRM, you have in early breast cancer. Sorry. Chemotherapy. When we should give chemotherapy in neoadjuvant and adjuvant. Neoadjuvant is before surgery. In all locally advanced breast cancer, that is big tumor, it has spread to the lymph nodes, it has spread to internal mammary lymph nodes, supraclavicular lymph nodes. In such cases, you give neoadjuvant chemotherapy. That is before surgery you give. What will happen if you give before that? If you give before surgery, it will Actually, I told you for Wilms
Reduce.
tumor, what will happen? It will
D number.
It will digress. So it will.
downstage.
Yes.
It will downstage the disease. Okay. So you give neoadjuvant chemotherapy in local advanced, downstage the disease, then do MRM. Okay. And you give CAF regimen. CAF and CAMF. It is nothing to like cyclophosphamide, erythromycin, 5-fluorouracil. No need to go into the details. Just remember, neoadjuvant is for locally advanced breast cancer. Adjuvant after surgery, when to give? It is you have to give when the lymph nodes are positive, when it is triple negative, or when it is HER2 positive. Only these are the specific indications. After mastectomy, if these are positive, then you give adjuvant chemotherapy. After surgery also you have to give, because these are dangerous diseases. HER2 new positive, triple negative, lymph node positive, they have worst prognosis, right? So you give CMF after surgery for chemotherapy. And when to give radiotherapy? So first indication, post BCS, all cases of post BCS, breast conservation surgery, you should give radiotherapy. Locally advanced breast cancer, you have to give radiotherapy. More than 5 centimeters or more than positive lymph node is there, also you give radiotherapy. Okay. Conventional accelerated is not necessary. Radiotherapy is given in these 4 cases. Post BCS, 1. Positive lymph node. If lymph node is positive, you have to give radiotherapy. More than 5 centimeters tumor, you have to give radiotherapy. Locally advanced breast cancer, you have to give radiotherapy. Okay. And then when to give hormonal therapy? I told you breast cancer, hormones also are positive. So when there are ER and PR positive, only ER and PR positive, then we give hormonal therapy. Hormonal therapy for premenopausal women, the serums are given. What is SERM? SERM. What is that?
Selective estrogen
receptor modulator.
Receptor
Okay.
modulator.
The example for it, tamoxifen, you give it for 10 years. Side effects are hot flushes, DVT, endometrial hyperplasia. This is for premenopausal women. For postmenopausal women, you can give aromatase inhibitors like letrozole, which is given for 10 years. The side effect is osteoporosis. Okay. If HER2 new is positive, then you can give trastuzumab. It is a monoclonal antibody. HER2 new positive only you can give this. Okay. This slide is also very important. Just again, I will tell you once. When you give hormonal therapy, it is only when ER and PR are positive, you give hormonal therapy. Estrogen receptor and progesterone receptor positive. So what treatment to give? In premenopausal, give selective estrogen receptor modulator. That is for tamoxifen, you give for 10 years. And side effects are hot flashes, DVT, and endometrial hyperplasia. Whereas in postmenopausal women, you give aromatase inhibitors like letrozole for 10 years, and you give the side effect is osteoporosis. Okay. Clear?
So for letrozole, it's osteoporosis.
Osteoporosis. For letrozole, it is osteoporosis. For tamoxifen, it is other 3. Hot flashes, DVT, and endometrial hyperplasia. Okay. To summarize, once the treatments, I will just summarize. See, early breast cancer, 2 options. What are those?
Mastectomy.
Radical mastectomy.
Modified radical mastectomy. Not nobody is doing radical mastectomy. Everybody is doing modified radical mastectomy for early breast cancer. Okay. Other?
Breast conservative surgery followed by radiotherapy.
Breast conservation surgery followed by radiotherapy. Very good. And for locally advanced breast cancer, what to do?
Again, modified radical mastectomy.
Yeah, before that, you give before that
neoadjunctive
chemotherapy and do modified radical mastectomy. Okay. For metastatic, only chemotherapy, no treatments, only chemotherapy. So just remember this slide. Early breast cancer, 2 options: modified radical mastectomy or breast conservation surgery with radiotherapy. Locally advanced, neoadjuvant chemotherapy. Give neoadjuvant chemotherapy, downstage the disease, then do modified radical mastectomy. For metastatic, no options, only give chemotherapy. Clear?
Yes, sir. It's the hormonal therapy slide. 1 second. 1 second, please.
Hormonal therapy?
Slide, can we see it? 1 second?
This is very important slide. Hormonal therapy, for those patients who are ER-PR positive only, we'll give them. Not for every patient. You'll do a hormone immunoprofiling, right? Histoimmunological examination. Once the immunological examination comes like ER and PR is positive, then you can select the patient, whether it is premenopausal or postmenopausal. If she is
Okay.
premenopausal, then give SERM like tamoxifen for 10 years. So hot flushes, DVT, and endometrial hyperplasia are the side effects. And for postmenopausal, give aromatase inhibitors like letrozole again for 10 years, where osteoporosis is a side effect. Okay.
Okay.
Yeah. So now we completed breast cancer.